Welcome to the PowerPoint talk of the chapter Rehabilitation of Acute Spinal Cord Injury. My name is Karl Zipser and I will guide you through the basics of spinal cord injury, or now abbreviated SCI. So SCI leads to neurological impairment affecting upper and lower limbs, lower urinary tract and bowel functions, acute and chronic pain syndromes, and other SCI-specific complications. Neurorehabilitation aims at promoting mechanisms of neural repair and reorganization or compensatory movement strategies to achieve functional outcomes. Medical disciplines involved in SCI rehabilitation are neurologists, spine surgeons, and neurourologists. The severity of the neurological impairment, complemented by spinal MR imaging and neurophysiology, provides means for the prediction of outcomes. In the following, we will introduce you to main concepts of outcome prediction, motor rehabilitation, and autonomic dysfunction, as well as SCI-associated secondary conditions. First, let me briefly introduce you to the clinical examinations of SCI. The clinical examination is key to the assessment and appreciation of the acute injury condition, prediction of outcomes, and medical or surgical care after traumatic SCI. Neurological impairment may range between complete and incomplete para or tetraplegia. In SCI, the examination is performed according to the international standards for neurological classification of spinal cord injury. The neurological level of lesion is determined by light touch and pinprick testing. Please follow the red box at the right side examining each segment. The last segment with normal light touch and pinprick sensation is called the sensory level. The red box now stopped at the sacral level S4, S5. The definition of complete versus incomplete SCI is based on the sacral status, where any sensory or motor function in the segments of S4, S5 determines the completeness of the lesion. Therefore, the sacral status is essential when examining SCI patients. For more information on SCI examination and for an explanation of the ASIA impairment scale scoring, please refer to the website of the American Spinal Injury Association. In addition to the clinical exam and MRI, neurophysiological studies, including motor and somatosensory evoked potentials, the sympathetic skin response, and spinothalamic evoked potentials contribute to the estimation of the outcome, detect neurological comorbidities, provide quantitative measures, and may refine the lesion level. More than 60% of acute SCI patients without recordable SEPs will have an unfavorable outcome in respect of walking. Similarly, tetraplegics with loss of ulnar SEPs within the first 4 weeks after trauma have a poor functional outcome for hand function. Regarding MEPs, most patients without detectable MEP in the first 15 days after trauma are prone to be categorized AIS A to C with a poor outcome of walking function. Let me now briefly introduce you to motor rehabilitation. The rehabilitation of any motor function is complex and facilitated by compensation, restoration, repair, and reorganization. Compensation implies the use of uninjured partial functions to accomplish specific tasks, for instance using the shoulder and trunk muscles to move the arm, when the injury is at the level C6. The individual roadmap to neurorehabilitation depends on the level and completeness of lesion, on the physical condition before the trauma, and on the presence of STI-related complications. Any locomotor training is established stepwise following the grade of mobilization from early stages to later stages. At later stages, for gait and balance training, robotic-assisted overground walking, body weight-assisted walking may yield better outcomes than conventional walking therapies. Technical innovation is a key driver for advances in neurorehabilitation. Neuromodulation with non-invasive and invasive electrical spinal cord stimulation, transcranial magnetic stimulation, as well as neurorestorative pharmacological therapies, are emerging methods that are discussed at the end of this chapter. Now, let me introduce you to another very important topic in STI rehabilitation: autonomic nervous system dysfunction. STI usually affects the autonomic nervous system, which needs to be monitored and assessed at an early stage. Let us guide you through autonomic dysreflexia, just one symptom of extensive autonomic dysregulations. Please remember the others mentioned on the slide, being neurogenic bladder disorder, neurogenic bowel disorder, sexual dysfunction, pseudomotor dysfunction, and orthostatic hypotonia, to be of same importance, and please refer to the STI rehabilitation chapter for more details. In STI at level T6 or higher, autonomic dysreflexia may be triggered from urinary tract infection, full bladder, fecal impaction, and pressure ulcers. You may follow the pathophysiology in steps 1 to 7 in the figure. Basically, autonomic dysreflexia is caused by an imbalanced reflex sympathetic discharge. Resulting from the trigger, an afferent stimulus is generated and carried through the spinal cord and cannot be controlled from supraspinal inputs adequately due to the spinal lesion. Below the level of lesion, a massive sympathetic response occurs, leading to widespread vasoconstriction. Vasoconstriction leads to systemic hypertension. In severe dysreflexia, systolic blood pressure may rise over 180 mm mercury. At the same time, the baroreceptors detect elevated blood pressure, giving a signal to slow the heart rate. The patients experience severe rapid high blood pressure, facial flushing, sweating above the level of injury, and headache, which quickly resolves after treating the trigger. At last, let me introduce you briefly to 3 examples of STI-associated conditions to care in STI rehabilitation: spasticity, decubital ulcers, and neuropathic pain. Spasticity is highly prevalent in patients with SCI, foremost in patients with severe motor incomplete cervicothoracic injuries. It may require medical attention in up to 1/3 of the patients. Although spasticity is not considered a type of pain, it may be perceived painful and interact with other types of pain. Drug therapies include oral administration of baclofen, tizanidine, tetrazepam, tolperisone, dantrolene, and clonazepam. In severe lower extremity spasticity, intrathecal baclofen with a drug-applying pump is an option for those patients with therapy-refractory lower extremity spasticity, or when the side effects, which are mostly tiredness, outweigh the benefit. Intramuscular botulinum toxin injection is an alternative for the relief of disabling focal spasticity. Skin pressure injuries or decubital ulcers are an important STI-related complication which may occur within weeks following trauma or in chronic immobile patients due to obstructions of capillaries from external pressure, friction during transfers, shearing from tissue, and moisture. Skin pressure injuries may be life-threatening when systemic infection or osteomyelitis develops. Common pressure sites are illustrated in the picture. Most stage 3 and 4 ulcers require hospitalizations, whereas milder injuries may be managed in the outpatient setting with regular consultations. The treatment of most hospitalized patients may take at least several weeks, which is challenging for patients and has a significant economic impact. Therefore, patients should be educated at an early stage after traumatic STI about the danger of pressure ulcers and preventive strategies. An active lifestyle, frequent change of positioning, day and night, optimized nutrition, regular skin monitoring, smoke cessation, and an optimal wheelchair configuration may generally anticipate pressure injuries. Patients who suffered any damage to the central and peripheral nervous system often experience acute pain and may develop severe and lasting neuropathic pain syndromes. Neuropathic and musculoskeletal pain syndromes are also common sequelae of SCI and require multimodal and interdisciplinary management. The presence of pain reduces quality of life in SCI and, additionally, might worsen sensory motor recovery. The characteristic qualities of neuropathic pain are burning, electric shock-like, stabbing, pins and needles, and it may be triggered by thermal or mechanical stimuli. It is usually localized at or below the level of lesion. It may be localized in the lower limbs, as illustrated in the figure, but also localized in the upper limbs, depending on the level of lesion. Current guidelines recommend following first-line pharmacological strategies to be administered in chronic neuropathic pain: amitriptyline, duloxetine, gabapentin, pregabalin, and their combinations. Of those, anticonvulsants have strong evidence in SCI. Let us conclude with the following key concepts. SCI rehabilitation is an interdisciplinary approach. Physical examination of SCI should follow international standardized procedures. Functional prognosis should be determined to define rehabilitation goals. Novel neuro-restorative methods may reshape the future of SCI rehabilitation. Autonomic nervous system dysfunction, for instance neurogenic bladder disorder and dysreflexia, need to be assessed and treated at an early stage. SCI-associated secondary conditions, for instance spasticity, decubital ulcers, and neuropathic pain, have a relevant impact on the quality of life of patients and should be managed adequately. We hope you enjoy listening to this introduction. Please refer to the chapter for more details and an overview of recent SCI literature. Thank you very much for listening.